Thanks for joining us today.
Hello.
My name's Matt Malone.
I'm Rob Trepizer.
Yep. And we are the flight crew today for the JeffSTAT 4 aircraft. Our pilot, the man in charge today, is Ron Richards. He's going to give us a little go over of their part of it. There he is. There's the boss. And thank you for joining us today. So we set up with your teachers a little presentation because of everything going on in the world today. We usually like to go out to schools and sometimes land in the parking lot and give you a hands-on demonstration of the aircraft. But obviously, as you all very much know, things are different now for a little bit. So we're trying to do this virtually. Forgive us with some learning curves. We're learning as we go too. We've done a few already, but let me make sure. Oh, okay. So just bear with us with any technical difficulties and whatnot. But we'll try, hopefully, for you to get something out of this. And the basic layout today is going to be: we're going to go over our aircraft that we respond to 911 calls and to interfacility transports in. We will go in detail of what that means and what we are used for in these roles, and give you a little bit layout of the physical aircraft, some of our equipment, how we load patients in and out. We'll talk a little bit about those two types of response that we go on to 911 calls that you typically hear and see on the news of aircraft landed at a bad car accident, things like that, as well as someone's at one hospital that's very sick that needs to get to another hospital very quickly. We'll talk about that, and we'll then come back inside and sit down and have somewhat of an informal talk like this. I printed out some of the questions that your teachers sent us, and we will. I was looking over the questions, and it looks like kind of our spiel covers about 80% of these questions just as we go, but we'll try to hit on the ones we don't touch on, and then we'll at the end try to type in some questions and answers, and even if you want to unmute, even at that point, we'll keep it a little informal and kind of just talk back and forth, and we'll wrap it up. It'll be about 45 minutes or so, and we're gonna have fun. So let's head on outside. Grab the radios. Flip this around. All right. So we are. I'm gonna keep that on me so I can talk so they can hear me.
So this, and you got the ranks.
Yep. So, welcome to our base. We're down in Woodbine, New Jersey, which is on your way heading to the Jersey Shore Sea Isle area. About 10 minutes or so from there. This right here is our aircraft. It's a EC-135. It's one of 4 aircraft in the JeffSTAT fleet. We have 2 aircraft that are based in Pennsylvania, us, and another aircraft, JeffSTAT 1, are based in New Jersey, and we service the tri-state, South Jersey, Pennsylvania, and Delaware region. This thing, once it's started up and going, can fly at the equivalent of a car on the ground going just under about 160 miles per hour. So we can get people places very, very quickly. The 2 sections of the aircraft are where the pilot sits, and then there's in the rear where we sit, and we store all of our equipment, and where we place and take care of the patient. So we'll start with Ron up in the front. Have him go over a little bit. You want to hold the radio?
Yep.
All right. That's where the man sits. Thanks, Ron, for helping us out today. So as you can see, right up here is where usually my partner, Rob, the paramedic, will usually, sometimes they let the nurse sit up front with the pilot, but we'll sit. And Ron, when we get dispatched to a call, he'll get it over his phone. And what do you do from there, Ron, when we get a call? Initially, you'll check the computer, right?
Yeah, usually when we do get a call, we have on our iPad, we have an iPad for every aircraft. We have what's called a risk analysis. And we go in and we just fill out different categories of what we're doing. And it gives us points, like a point system. And the higher points, then the higher the risk gets up. I have to submit that to my observer controller on the other end of it, who observes it, just gives me a second set of eyes to look at it, and then we'll approve it. It goes green, and then we head to the helo and jump in and get moving.
Yep. A lot of things happen very quickly. Basically, what Ron says is there's an ambulance on the scene somewhere that has a very critical patient that they know they're, let's say, for example, in Cape May, and they know they are 45 minutes an hour away from a trauma center, they know that patient needs to get to the trauma hospital now for possibly emergency surgery, emergency interventions, they'll call for us on the radio. Once that request comes to us on the radio, everything moves very, very quickly. We get up from whatever we're doing, and Ron goes on the computer, starts submitting a risk, and our goal is really from the moment that person calls us that we are actually flying to them in hopefully under 8, 9, 10 minutes. So everything happens very, very quickly to go. So go ahead, Ron. So,
I'm trying to repop this up.
Yeah. Yeah.
Just a quick general just layout of the cockpit and how we fly. We fly single pilot, so I'm the only pilot. One set of controls. For a helicopter, this is very simplistic, so it's obviously more detailed. But we have pedals, and pedals are for direction controls. We think nose, left, and right. This is called a collective down here. Pulls, that's pulling your power. It's like your gas pedal. That pulls in my power now, make us go up and down. And then this is called the cyclic. And if you think of it, left, right, and more dexterity roll forward and out. We had some input failures, so I'm having some issues. We'll play with that.
Here we go. Yep.
Generally, you start the helo. This has a it's a digital control system that starts the engines.
Yes.
You just flip it up. It starts everything up for us. While I'm doing that, we're bringing up our GPS just for our navigation. So again, I'm not going to go into all the dials and everything, but this all tells you your airspeed and your altitude along the way. Our primary instruments are the Garmin navigation systems. So when we do get a flight, it might be a accident scene, they're going to set up a landing zone somewhere and give us a latitude, longitude numbers. All I'm going to do is, and these aren't spooling up yet, but I will program in that latitude, longitude, and then just hit, I'm going to go direct to it. And it gives us a direct line to where we go, gives us our distance, and how long it's going to take to get there based on our airspeed. Generally, when we're just flying to a position, we fly about 120 knots, so it's about 180 plus or minus miles an hour. We'll generally fly at about 1,000 feet. The helicopter can go a lot higher than that, or obviously lower than land. But we generally cruise around 1,000 feet when we're going somewhere. Again, you can kind of see some of the things spooling up. Basically, when we get overhead, all our instruments tells us we're there. We start on our radios. This is right here is all our radios. We're talking to people on the ground. We're talking to our communication center. And I'm also talking to air traffic control when I'm doing that. So we have about 4 radios we're talking on all at the same time. As we go.
So it's interesting. So Ron, so when we get dispatched to a scene, that parking lot of a school, they're not going to tell us it's 23 Main Street. They're going to tell you a longitude and a latitude, correct?
Yes, so they'll tell us that longitude, latitude, and then they're going to describe it. So if it's at your school, they might say whatever school it is at their parking lot. And then they kind of give us a description when we're flying there on the radio, what it looks like. We'll get overhead, we orbit. We like to do an orbit overhead. It's our reconnaissance. Just to look and see, to look for wires or obstacles, anything that might impede our approach or takeoff from the landing.
Very cool. Very cool. Hey, Ron, thank you so much. All right. Oh, thank you very much, Ron. Really, really appreciate it, man. Thank you. All right. Now we're going to take a step to the back. And, Rob, you want to hop in? I'm going to come around the other side. We're going to talk a little bit about the equipment that we use while we are flying on board with a patient. Jacqueline, the volume's good for everybody? You guys can hear us okay? Connection's good?
Yeah, I can hear fine. So I think you're okay.
Okay, good. All right, so everybody, this is the back of our aircraft, the JeffSTAT 4 aircraft, EC-135. As you can see, it's a little, not a whole lot of room. This is where I would sit. Rob's sitting in his seat. All right, and there's our stretcher with some of our equipment. We keep things strapped to the stretcher, obviously, so we can get out and go quickly. And I'll have Rob explain a little bit what we use and where we put things and whatnot. And go ahead, Rob.
All right, so this is how it works. Technically, anytime we are dispatched to the call, means a scene job, accident on the highway, or anytime we got dispatched to like hospital. Okay, so my first job is to sit in front with the pilot. Okay, that's without the patient. If we have the patient already, my job is to sit over here in the back with Matt. So the pilot runs in front by himself, and Matt and I sit over here. So we have the 2 seats. We have a stretcher. Now, just remember that when we have the patient, all this equipment is on the side.
Yep,
all
yep,
right?
and up on the bracket there.
Exactly. So the first thing we have, not all the patients that we do are getting attached, hooked to the cardiac monitor. Okay, and this is one of the cardiac monitors that is actually utilized by a lot of companies through Air Medical. It's very light and very portable. Okay, so this is your right over here. You're going to have your EKG. You're going to have your blood pressure. You're going to have your the little pulse ox that monitors the oxygenations as well. Also cables.
And what are those pads
like
used for,
so
Rob?
the pads like this is actually a pediatric pad. If you guys are familiar with little AEDs, defibrillators on the walls in the school,
Yep.
this is actually one of those things that are a little bit more complicated. Yep. So this basically, if somebody's heart starts working and goes into cardiac arrest, we hook this up to the patient and try to help
Yep.
them out.
And now the monitors that you see at your school and hanging at the mall, those are an AED. They're automatic, so the machine will actually read the patient's heart rhythm, and if it thinks that it's a rhythm that is shockable, to convert the patient back to a normal heart rhythm, it'll just tell you to shock. This one, we put the pads on, and Rob and I look at the heart rhythm, and him and I discuss, okay, that looks like something that's shockable that we can, because there's only certain type of heart rhythms, right, Rob, that can be shocked.
Exactly, right?
Yep.
Only two, huh?
Yeah, only 2. Yeah. Yeah.
All right, so what else we have? We had a SIM bag, okay? This
Yep.
bag goes with us everywhere, okay? So technically, if we are calling an accident in the middle of the highway, okay, we landed, we walk with the stretcher, we take this with us. There's a lot of stuff that we actually need in this SIM bag. There's multiple pouches that we actually utilize, but the most interesting that you guys want to see technically are the intubation equipment, okay? So let's say somebody is in such a bad condition that needs to be, we need to help him breathe, okay? So we have equipment to do that. And one of those equipment is actually a video scope.
One of the best tools that has come out
Yep.
in the years.
So the way this works, you actually turn it on, and if you
That little tube,
Yeah.
we put a clean piece of plastic right on there.
right, the clean plastic like this, and goes through your mouth, and we can see the vocal cords, okay? So now with the vocal cords, let me just turn this off. We have this tube over here, okay, that actually, using the video laryngoscope, we're looking, visualizing the vocal cords, and we put in this little tube through your vocal cords, and then we can actually help the patient breathe.
Yep.
There's different sizes from actually 2.5 to like 8.5, and depends from size of the patient.
Something that small to
Exactly, right?
Yep.
And
And-
now, once the patient is intubated with this stuff, we actually use this machine, which is actually a ventilator.
And you've heard a lot about this in the news recently.
Exactly, right?
Yep. And this is a very small, somewhat complex but easy piece of equipment that we use for both scene calls and interfacility calls to breathe for the patient. And you might ask yourself, well, why are we breathing for the patient? The issue would be is that someone, obviously, if they're just not breathing adequately, if they have very bad lung problems, if they have a very bad sickness that has caused them to be unconscious, we worry that they're not able to breathe for themselves. And then we step in, we put the breathing tube in, or we hook them up at a hospital where the doctor has already put a breathing tube in for them, and we hook them up to this ventilator here. And what this ventilator does is, as complicated as it looks, it does a few basic things, which each of us do with every breath we take. It delivers a set volume of oxygen and air which we all breathe at 21% oxygen now. We can give a patient up to 100% oxygen with this. And just like imagine if you were holding a balloon to your mouth right now and you blew into it, each of us normally as grown adults breathes about 400 to 500 of a tidal volume. We can set this ventilator based on your size and height and weight to what we approximately believe your lungs would breathe on a normal day. And we could go on and on about all the different pressure settings and things like that, but at the end of the day, that's the basic description.
Pretty much, yep.
Of what a ventilator does. So we'll step out now and we'll kind of show you a quick little demonstration of how we actually load a patient in and out of the aircraft. All right? That
So
sounds good?
just remember, if we go to a scene job, accident on the highway or ambulance coming to, like, let's say a parking lot at the school, the pilot's going to land the helicopter, and most of the time, I would say 99% of the time, he's not going to shut down. Okay, so it's important to remember, especially for the future. Let's say this whole pandemic thing's going to go away, and we're going to get invited by the school to come over. It's very important for you guys to remember not to come close to the aircraft when you have the rotors spinning around. Okay, you have to stay away, very, very far away from this aircraft. So this is a very important note for the future.
Yep. And it's something that we are always thinking about when we're working around the aircraft, because there's a lot of fast-moving parts and. All right, so here's the back of the aircraft. This is what we call the clamshells, and how it'll work is we flip it open, and as you can see, that's where we keep our stretcher to the side, and our inter-facility bags are here strapped down. We have them covered in plastic just to keep any particles and things going on now with COVID. But and this is our bag that we keep our pumps in to deliver the medication. But what we would do on a scene is if swap spots, if you want to stand over there, it's held in tight, and we unclick it. This is how we pull it out, drop down. And actually what we would do is you would envision Rob and I would walk this over to the ambulance in the parking lot, say for a scene, or we would walk this into a hospital. We would take our equipment off and we would actually slide the patient from their stretcher. We would take them out of the ambulance, slide them over on our stretcher, strap them down, put the bag on our back, put the monitor between their legs or hook it on the rail, load them up quick. We try to be in and out of a scene from landing to going in 10 minutes, 10, 15 minutes tops. And sometimes we have to be there longer. Vehicle, whatnot. I mean, there's things out of our control. But when all said and done, we'll load the page back up, put it together, put a little hip into it, and do a support part. Make sure it's strapped in. Put our oxygen here. These. Little demonstration of what, because some medications you see on TV, they're just hanging from a tube, hanging on a pole, but a lot of medications we use are very delicate and have to go in the patient very specifically, a certain rate per hour. So what we use these are these little pumps, and all we do is we put our tubing in through this pump, we turn it on, we put in how fast we want it to go, the rate, 10 cc's an hour, 100 cc's an hour, bolus 1,000 an hour, blood, whatever we're running, we hit start, and then it goes at the rate we tell it to go. We carry 3 of those pumps with 2 chambers each, so we can run six IV medications at once on a patient. So that's the basic little overview of our aircraft. I'll have Rob do a little step back and look at the whole thing, and then maybe we'll walk inside and talk about some of the calls we've got. So, the biggest thing you have to think about for helicopter EMS is Rob and I and all our crew, we train very hard. We're going to go inside and talk about the schooling that was required to become a flight nurse or flight paramedic. And we do very critical skills with bleeding control and airway management, things like that. But also, and one of the biggest things you have to remember at the end of the day with our presentation is the biggest thing we give patients is time. And that's the whole purpose of air medical. Rob and I both worked on the ground for many years, and there's really no difference in our training from the guys that work in the ambulances and the paramedic units. We have some different classes in essence related to the safety of the aircraft, but our training and our certifications are all the same as the men and women that respond to you on the ground. Let me turn this camera around.
You want to show them the quarters before we do that?
Oh, yeah.
So this is our quarters, okay?
Yeah.
This is like a main, what you say, like a living room, okay?
Yeah.
We have three nice sofas, we have a pretty nice big TV.
Yeah.
We have a little kitchen over here.
Mm-hmm. Rob's
actually,
always cooking something good.
pretty much.
Yep.
You know,
You have to think of it. We're a 24-hour operation, and we don't. Not like when we're working in the ambulance that we're able to get up and go to Wawa and whatnot. So really, sometimes we work. We always work at least a 12-hour shift. Sometimes we'll work a 24-hour shift. So, we try to have some of the comforts of home. We do each have a rest area as well as the pilot. Because obviously, if we're working a 24-hour shift, we need to be able to lay down for a little bit. Just like if you have any friends or family members that are firefighters, they work 24-hour shifts. We need somewhere to rest a little bit, or if we've had a couple calls back to back, it can be very exhausting. But as I was saying, the big thing with helicopter EMS that you have to remember is we give the patient time. They are at the tip of Cape May, and to drive that trauma patient who is profusely bleeding, God forbid, to Atlantic City trauma could take upwards of an hour to get there. We can do that flight in under 13 minutes flight. So we can get them to the hospital, get the blood transfusion, and get them to the OR before they would even be showing up to the door at the trauma
well, even
center.
longer ones. We can get. We actually go to hospital in Delaware where you need almost 2.5 hours to 45
2 hours
to drive from that little hospital in Delaware to Philadelphia. It takes by car, by ambulance, 2:45. We can do in 45 minutes.
Yeah,
even less than that. So
because you got to remember, we're not taking roads. We're literally lifting up from point A, flying across, and going down to point B. So that's where we really cut a lot of that time out. So I guess we'll start with we'll talk a little bit about nursing now and paramedic science. This whole program kind of morphed out of the concept of some career days that we were scheduled to go to. So we try to key on the importance of that too, showing you the aircraft, talking about flight nursing and flight paramedic science. But the key to remember too is that this job, I've been a nurse. This summer will be 15 years. Rob, you've been a paramedic
since 2006.
Yeah, so another 14 years or so. So this is a job that many years down into your career you get to possibly dabble in. But I wanted to do it since I was 16 years old. So this is something that is very obtainable, but there's quite a few jobs that you're going to have along the way, and education and things to get to this point of nursing or paramedic science.
I think there is a saying to it: get a job that you love, so you don't have to work a day in your life. Right?
It's true. It is true. It is.
So
true.
this is what we do. We love this.
Yeah,
we really do.
It is. It's a lot of hard work, stress, but it's a lot of fun. So we'll talk about nursing first. It's very popular right now in the news, and being a paramedic as well with the pandemic going on. Nursing is a very rewarding career, but
not easy.
It's not easy. And Rob actually just got done nursing school too, so he's almost just got to take his boards, and he's a nurse.
I want to be like him when I grow up.
He wants to be he'll be a male nurse too. So the beauty about nursing is, though, men, women, all races and creeds and different things. So my basic spiel about nursing is that there are a few different types. So there's a licensed practical nurse, is a nursing program that a lot of community colleges have, where it's about a 1-year program, and you are certified, licensed to be a licensed practical nurse, in the sense that you are not a registered professional nurse, and that's an RN that you hear. The licensed practical nurse is a 1-year program. You work under a nurse, a registered nurse. You can give medications, you can give shots, but you are not very involved in the planning and whatnot of the patient's care. It's very licensed practical nurse. You're doing the practical nursing, the medication passes, the IVs, the pill pass, things like that. Very good job. You often find licensed practical nurses in the long-term care settings, the veterans homes, nursing homes, rehabs, things like that. That's a very popular setting for that type of nursing. Next step up is the registered nurse. There's 2 types of ways that you can become a registered nurse. Well, there's 10 different ways now with all the different programs out there, but the 2 most popular are an associate's level program and a bachelor's level program. Commonly understood is an associate's level is equal to about 60 credits, and full-time would take someone about 2 years. A bachelor's level program is 120 credits roughly, and a 4-year program.
But remember, with nursing, it's 2 years only nursing school.
Yeah.
You have to have your prerequisites done before that.
Exactly.
Okay, so that's very important, because some people say, "Oh, it's only 2 years." Actually, comes to 4 years, right? Because you need your Englishes, APs, maths, sciences, right?
Yeah.
So technically, it's a little bit more than 2 years.
And some programs won't even accept you without taking your prerequisites because of how popular the schooling is now. When I started, they let us do it at the same time, and that was super intense. But a lot of programs now want you to show your brains a little bit by getting really good grades in the prerequisites of the nursing program, which involves anatomy and English and
unless you go to BSN, obviously, right?
Or you do a BSN program, which is the 4-year program, which is the 120 credits roughly. At the end of the day, I want you to understand, though, that the nurses that go to an associate's program or the nurses that go to a bachelor's program, as crazy as this sounds, sit for the exact same nursing boards at the end of the day. So you go to a Pearson VUE testing center, and you take your nursing boards. At the end of the day, you're issued a license from your state. That's the same for the associates and bachelors. I know it sounds crazy, but that is how it works. And someone would ask, well, why would I go to a 4-year program if an associate's program is going to give me the same nursing degree? And all I can say is there's nothing against an associate's level program. Rob just got done an associate's program. I graduated from an associate's program. But the times have changed a little bit, that to be a little more competitive in the market, I would strongly recommend, if you are a high school student and no responsibility, no kids, no house yet, to just go ahead and just go for a bachelor's program, because it now the market, some hospital base.
Actually, I think 100% of the hospitals would not hire you with associate only.
And that's hard to say because Rob just graduated that program. So it's
but I'm already grandfather.
Yes, he's grandfather because he's been at the hospital a long time.
Right.
But someone coming in out of high school that did an associate's program, not that you will not find a nursing job, because trust me, you'll find a nursing job. It's just if you are really striving that you want to do hospital nursing, Atlantic Care, Jefferson, Inspira, Virtua, hospital-based nursing in an ER or an ICU, things like that, you will need a BSN, a bachelor's in the science of nursing. Associate's level, though, you can work at rehab. Oh my God, you can work plenty of different places. Nursing home, home-based care. You could work in that nursing home with those LPNs. Your job would be a little different than a licensed practical nurse. You'll give meds, you'll see the patients, but you'll be more of you might be the one RN on with 4 or 5 LPNs.
You'd be in charge.
You'd be the supervisor. Yeah, you would be in charge.
Yeah.
You'd be trained to be the overseer of that setting. You could work in a surgery center. So there's plenty of different jobs out there. But that's just feel. You want to go on, you can go on within the career, which I and many of the nurses here, all of them have, is you can get specially certified. You can get specially certified in your specialty. I'm a registered nurse, as my wife is, and all the other nurses here. We are specially certified CCRN certification. That means we have worked the job for quite a few years in critical care and sat and took a special boards exam to pass to become critical care certified. Nurses that work in the emergency room will be CEN certified, emergency nurse certified. If you work with cancer patients, you can be certified in that realm, certified oncology nurse, things like that, certified OR nurse. And it basically is a little special designation that you are specially trained in that part of nursing. You graduate nursing school, that's just the blanket of your career. Then you pick which kind of nursing you want to get into.
And most of the hospitals, not all, but most, every time you get your certification, you adding some dollars to your base rate, right? It is important, though.
Rob with his gold chain. He's going to talk about the money aspect of it. Oh, yeah, there's financial. Well, you're not going to do nothing for nothing, so you're going to, there's incentives to go on with your career. And then after a bachelor's, the next thing would be to get your master's in nursing. And with a master's, we'll teach nursing students. And then you go on from there, you can get your doctor of nursing. As crazy as that sounds, you are a doctor of nursing science. Someone says, well, what does that mean? That's like when someone is a doctor of psychology or a doctor of physiology or anything like that. And you again can teach, and you can actually pursue, in essence, between a master's and a doctorate. There's what you have heard of as a nurse practitioner, is an advanced practice nurse that has extra training paths, his bachelor's, to actually see patients with a overseeing doctor. You can write prescriptions. You can be a NP with a surgical group and help do surgical procedures. You could see patients in a critical care setting, in an urgent care, all things like that. So, but that's my little spiel. And if you have further questions, you could forward them to your teacher, and we can go on. I'll look over again, see what we haven't touched base here with these questions. I'm going to let Rob talk for a few minutes about what's involved in becoming a paramedic, though, too, so you can hear a little bit about that.
Okay, so paramedic is a little bit different, but not much.
Not to mention, you do both radios?
Yes.
The aircom radio?
So to become a paramedic, first you have to be EMT, which is emergency medical technician. Nowadays in New Jersey, it's about 240 hours to become EMT, and you get in your basic job as an EMT, most likely with a transport company that you taking patients from or to the hospital. You can also get a job in a local 911 service. Most of the towns has 911 services provided to them. After that, you need about 2 years experience as an EMT, and you can apply to a medic school. Medic schools are run throughout the colleges, community colleges right over here, but are kind of incorporated with hospital settings. So Virtua has their own medic program. Does Inspira has it? Medic? No, they don't. No. Atlantic Care has it, and it's about 2 years program. Some Virtua, I know Virtua has an associate at the end. Atlantic County College has just a certifications, but you can take that credits and continue with the associate degree as well. It takes about 2 years. You technically need a 1 year of didactic and about 520 hours of riding time practicing on an ambulance. So that's 2 years. Later on, you can, like me, like after the medic school, I went to do my nursing school, and this is practically with the medic. A little bit easier than the nursing school, though.
Yeah. Different than nursing.
Different, yeah.
The best spiel I give, and this is going to kind of lightly touch on some of these questions here, is the difference between a nurse and a paramedic you have to think of is the goal of the training. The training to become a nurse, registered nurse, is that you are taking care of patients from babies to seniors, and you are looking at the whole picture of the patient. A patient that's very sick, that nurse, not that specific nurse, her or him, but that nursing profession is going to look at the patient as far as they're very sick. Let's medically get them better, but let's also look at them in a sense of they're going to need rehab after this. They're going to need home care. They're going to things like that. They're going to be the manager of the care of the patient, coordinating with physical therapy, coordinating with the respiratory therapist, all those involved in the picture. The nurse is kind of the quarterback of all the things that are going on for that patient while they're admitted.
Exactly.
Involving critical care. The patient's heart stops. The nurse is the one that's running in the room and going to start pumping on their chest and giving drugs and things like that. They're part of that critical care aspect. A paramedic and an EMT's training is that the golden hour that you've heard of.
Right. So what we do, somebody call 911 for emergency, any emergency, right? If you call 911 for bellyache, most likely your local ambulance is going to come over, okay? Equipped with two EMTs. But if you call for chest pain, shortness of breath, the same local, life threat, right? The same local ambulance is going to come, but follow-up is going to be a paramedic unit, okay? Paramedic unit in New Jersey has two highly trained medics that will, treat you for that condition. And we can do a lot of stuff. We can give multiple medications. We can start IVs. We can intubate, So our goal is to make you better from the time we get to your house to the time we get to the hospital. So we usually spend 45 minutes, maybe even less sometimes, minute with the patient, versus with MAD, we'll spend sometimes,
a whole shift,
shifts
in a row in the ICU.
So that's the difference between the medic thing and nursing care.
That's the best kind of understanding of it, is that the paramedic is trained for 2 years or however many hundreds of hours, Rob said, with ride-alongs, things like that, for all the things the patient's going to need in that critical time from calling 911 to getting to the hospital. The nurse is trained in everything from getting into the door of the hospital to getting home. So, So,
and beyond.
Yep. And quick thing we'll touch on too is these are the radios that we're dispatched on, and there's two different types of radio systems that we work off of. I forgot to touch on. I'm looking at some of these questions you have here. But how we're dispatched is if it's a 911 scene call, the local ambulance will call their dispatch center, who then calls a company all the way up, as crazy as it sounds, in North Jersey, REMS, and they will see who is the closest aircraft to that car accident, heart attack patient, stroke patient that needs an aircraft. They will pick which one is the closest and dispatch us. They'll say, JeffSTAT 4, go request.
REMS is responsible for dispatching all, was it 12 right now or 13 helicopters in the state of New Jersey. Okay, so they monitoring the whole helicopter traffic. They're dispatching the closest helicopter to the scene, and that's only for the scene jobs.
Yeah, for the scene jobs. Now, for an inter-facility transport, hospitals set up relationships with private companies like us, JeffSTAT, Cooper has a few aircrafts, Hackensack, there's a couple different companies that JeffSTAT partners with a company called Air Methods, who we are partnered with.
Right.
And we have a relationship with, obviously, Jefferson Hospital, Atlantic Care. We have a different relationship with hospitals that when they have a patient that's very sick, they call a special phone number that then calls us as the closest aircraft. We're right up the road from Cape Regional, Shore Memorial Hospital, all the Atlantic Care facilities, things like that. And that call, as crazy as it sounds, goes up to Jefferson in Philly, which then goes over to Nebraska. This all happens in under 2 minutes. I mean, it's a very quick system in place that one place calls, it ripples effects, and then over the radio, they will alert us that we have a STAT inter-facility transport to go to right now. And that's how it works. They'll give us the hospital name. A very brief description will come across our phones with the patient's weight. Big thing is weight for the aircrafts, that we everything's weighed and whatnot, and we'll go to that hospital, pick it up. And those we don't have to punch in necessarily the GPSs and all, because we have all the hospitals programmed in. So Ron actually has a special code. You can pick the hospital that we're going to, and it'll show us right how to get there. That's our spiel. We'll go over now. We'll start answering some of these questions, and then if there's anything left, we'll take a few at the end. So
for stat test films, how many?
What we got?
Aircom, JeffSTAT 4, here's your loud and clear. Thanks a lot. Thank you. And that's exactly how we would get dispatched. So if that was going off right now, we would be jumping up, grabbing our helmets, and heading out the door. Rob would be putting in his risk assessment. Look, I got Ron to even stand up. He didn't know they were doing that. So yeah.
This
He could
is
stand down.
this is actually, we didn't show it to you. This is the helmet we have.
Yep. And that's to protect us, because a lot of times things with turbulence and whatnot in the aircraft, there's a lot of sharp, tight corners in there that we just to kind of keep our heads protected, as well as our ears protected, so we could talk to each other. It's very, very loud in there.
It is loud.
So it keeps our ears covered. So I could talk to Rob, we could talk to Ron, we could talk to the radio control on the ground where we're landing. We could talk to the transfer center, all the different things we need to talk to. We actually have a satellite phone. If we need to call our doctor to run something by him or her, we're able to do that. So